This is our second webinar for the DBA Healthcare Leadership at Middlesex University. I'm joined by colleagues today, Roger Klein and Professor Joy Wilmington, who led our first seminar and co-authored the report Too Hot to Handle. Roger and Joy will chair today's event, and we are delighted to welcome Professor Jill Maben and Justin Aunger, her research fellow, who will be talking today about unprofessional behaviours. So I'm going to hand over to Roger now, and later on we'll pick up with you with the Q&A. Thank you.
Thank you very much, Mary. So I'm just going to introduce Jill, who in turn will introduce Justin. So I'm going to read Jill, so I'll make sure I get this exactly right. So Jill is Professor of Health Services Research at the University of Surrey. She's undertaken national and international recognised nursing and healthcare research. She's a nurse by background, and her programme of work seeks to understand the links between staff well-being at work and patient experiences of care. Jill's work has investigated the emotional costs of caring and what supports staff to do well. She's been a member of prime ministerial commissions. She's the board of the Point of Care Foundation, was a member of the Health Education England Commission, and so on and so forth. So she is an authority in this area, and her most recent piece of work, which she did with Justin and colleagues, I think is a kind of significant contribution to an understanding of unprofessional behaviours. So I'm going to shut up, Jill. I'm going to hand over to you, and you'll introduce Justin when you want to.
I will. Thank you very much, Roger. Thank you. Thank you, Mary and Roger and Joy, for the invitation today. I'm really, really delighted to be here, and going to share some of our recent work with you. As Roger has said, I am most interested, my work has for about 20 years been looking at supporting how to help staff care well. So looking at staff well-being, psychological well-being, particularly in the workplace. And so I come to this work with that lens particularly, but also did some work evaluating links between staff well-being and patient experiences of care. And in that ethnographic work did see some incivility and unprofessional behaviours, which I have to say at the time was quite shocking, sitting in a staff meeting where staff were rolling their eyes and being very rude to each other, with me, a stranger, in the midst. I then did some work evaluating the freedom to speak up work, Guardian work. Did the first national evaluation of that led by Aled Jones. And that work, obviously, as many of you will know, despite being focused by Robert Francis on patient safety, had over half of issues raised to Speak Up Guardians were about bullying and harassment at work from staff. So I come to this work with that background, but today this is what I'm talking about. This is our most recent work. Oops, sorry, didn't mean to go. There we are. So I'm talking today about this work we've done looking at addressing unprofessional behaviours between healthcare staff. So we're looking at staff on staff behaviours, not patients towards staff, or staff towards patients. That's another whole ball game and another piece of work. And this was work undertaken with a big team of us. I led the team, and Justin, who you saw on screen, was the research fellow. So he was the hard worker. He did a lot of the work and read a huge number of papers and helped pull the analysis together and come up with our recommendations. So I'm really delighted Justin can be here with us today as well. We've also got international experts, Professor Joanna Westbrook from Macquarie University, and I'll come back to her work because she's implemented a programme trying to reduce unprofessional behaviours, bullying, incivility in Australia. So I'll come back to that as a case study. So what's the problem? We know, I'm sure most of you on this call, and certainly if you were at the last call webinar with Joy and Roger, where they launched their Too Hot to Handle report. The data on this screen will not be a surprise to many of you, particularly the disproportionate amount of bullying, incivility and harassment that is experienced by minoritised groups. So this data here is from the 22 staff survey and also from the Workforce Race Equality Standard data. So this is the problem. And what we wanted to do in our study was take it broader than bullying and harassment. We wanted to look at what we determined as unprofessional behaviours, quite a loose kind of big umbrella term. But what we meant by that was any interpersonal behaviour, and we do mean interpersonal behaviour, by staff that causes distress or harm to other staff in the healthcare workplace. These we know impact patients' safety and patient experiences of care, but also staff wellbeing, causing staff considerable stress, distress, and causing staff to not be at work or to leave organisations when they can't remedy situations or are unheard. And we focus, as I said, on behaviours between staff, not between staff and patients or patients and staff. So what I'm presenting today is our findings from our National Institute of Health Research funded realist review, and I'll explain a bit more what a realist review is in a minute. So we're looking at contributors to unprofessional behaviours or drivers of that, and interventions and strategies to mitigate this. And we used our findings to develop a guide for organisations to address unprofessional behaviours between staff, and I'll come on to that. And a lot of the content of this presentation is in that guide, as well as in our academic papers and report. But I'm going to give you references to all of those and how to access that shortly. Excuse my voice, I'm recovering from a cold and sore throat, so I hope I managed to carry on. I've got some water, but forgive the croakiness. So here is our guide. And we've got a few hard copies, but mostly it's available online, and I'll show you how to get hold of that later. So what did we do? So we did this review for a couple of years, took a long time, and we found 148 sources from healthcare settings like those in the UK. We started with the UK, and there weren't many interventions in the UK actually, so we broadened our search and we included Australia, USA, Canada, and other systems that like our own that were quite well funded. And we found 42 reports of interventions, and we focused initially mainly on acute care settings. That's mainly because a lot of the work has been done there. That's not to say that unprofessional behaviours don't exist in primary care and community care. I'm sure they do, but there's not much written about it in those settings. So we focused on acute care settings. And the 42 reports were what we found up to December 2022. There may be some recently. We're not aware of many, apart from the work Joanna's been doing, which I'll come back to. So we drew our findings together to identify, as I said, contributors to unprofessional behaviours and create theories of how and why interventions might work. So why did we do realist methods? Why didn't we do a systematic review? We felt we've done reviews like this before, and we feel realist reviews go beyond does something work and ask more interesting questions that are more relevant to managers and people in the healthcare system, so they understand why does it work, how does it work, and for whom does it work, and in what settings. So we know that in different settings it might work differently. So context matters. And healthcare is a space where how and why interventions should work are often poorly explained. So we wanted to explain that a bit better. Unpacking this enhanced our knowledge of how interventions can be improved. So this is a bit of a complex diagram, but really all I want you to take from this is that we started with initial programme theory, drawing on the literature. We wrote our proposal with the literature we knew about, this sort of key reports. So we built an initial programme theory, and then in realist methods, you test that theory in an iterative way with new material. So as you search and bring in new bundles of reports and published papers, you test the theory and refine it. So it's quite an iterative circular process, and the green boxes will tell you that at various points in our process we included stakeholder input. So that was some patients and the public, but certainly staff who'd experienced unprofessional behaviours. People like Roger and Joy were a part of our stakeholder group who helped us make sense of what we were finding and directed us to other literature or other ways of interpreting. So thinking about the contributors to unprofessional behaviour, we identified 5 main areas of context. So workplace disempowerment, harmful workplace processes and cultures, a lack of manager awareness and or urgency, a reduced ability to speak up, and where there might be inhibited social cohesion. And what those contexts triggered in mechanisms were the increased likelihood for staff to engage in unprofessional behaviours, a reduced ability to cope with them, and to report, challenge, or address them. And so the resulting outcomes were an increased presence, reduced patient safety, as I've said before, impacts on staff wellbeing, and ultimately poor care quality and experience. We've recently published a paper looking at the drivers of unprofessional behaviour. You can see that at the bottom of the screen, and that QR code hopefully will work. So if you point your camera at that, you might take you directly to that paper with a bit of luck. So moving on to interventions and strategies, there's much more about the drivers in our report. I'm having to give you a bit of a whistle-stop tour today, but in terms of interventions and strategies, what do we mean by this? So interventions are more of a broader term that includes strategies. So interventions are the coordinated sets of activities. They typically comprise both the means of delivering strategies, so that might be written materials, lectures, role play, psychological techniques, whatever, the strategies themselves, and the evaluation methods assessing their effectiveness. And then the strategies are what we call the active ingredients within interventions that try to change behaviour in specific ways. And so interventions usually include several strategies, just to be clear about what the difference is. So what strategies might be helpful? So across those 42 interventions we found in the literature, the majority were single sessions. May not be quite so helpful as ongoing sessions, but 11 had multi-sessions, and some had sessions with something else. So for example, sessions plus something extra of a code of conduct, or perhaps a reporting system or something else. Professional accountability was notable in 8, and very few had something that we call a structured culture change, so something more systemic about ways of changing culture. Mostly the interventions were education-based and trying to change hearts and minds, if you like, trying to get people to understand what unprofessional behaviours were, why they might be detrimental, how to be a good ally and how to speak up, and how to report them, but not necessarily changing some of those contextual structural things that we saw in an earlier slide. So what strategies are available and work? We identified many and collapsed them into 13. As I've said, an intervention usually draws on multiple strategies, so it's quite hard to say whether individual strategies work on their own or not. And those that we identified really are just those that we found and that exist, but there are plenty more to be developed. And in the little blue boxes here, you can see the different types. So focusing on individuals and trying to change, as I said, hearts and minds there, it might be improving awareness and knowledge or ability to cope. That's the sort of distal end. If you've been on the receiving end of unprofessional behaviours, you might want to help people cope with that. That's not going to change your prevalence of unprofessional behaviours, though. Improving confidence to come forward might, though, and making a direct approach to instigators. And then in groups, there might be, or as an organisation, social norm setting, improving teamwork, workplace redesign, improving leadership competence and empathy, etc., and changing recruitment processes. So we saw some examples of how important it might be to have something in induction, not only to have something in induction about values and norms and expectations, but have the chief executive there saying what it was and leading from the top and showing how important that was and how much it mattered. And then there's understanding the prevalence of unprofessional behaviours. You actually need to know what the problem is, particularly in your organisation, before you can do something about it, and what types of unprofessional behaviours you might have and in what pockets and where before you can intervene. And then have some way of aiding the implementation of any interventions, But external pressure from other organisations can also help. So maybe organisations like CQC or other regulators may actually help in terms of changing patterns of behaviour. So just giving an example here, work through examples. So thinking if I want to tackle workplace disempowerment and improve staff's ability to cope and speak up, what we've got here are a couple of ways of doing that. So I might want to improve confidence to come forward. And the way to do that might be giving assertiveness training, doing some role playing, cognitive rehearsal, and keeping records. I noticed 2 people have got their hand raised. I don't know if everyone able to hear and see. Is there an issue? I'll leave Christiana to deal with that, if that's okay.
I think it's okay, Jill.
Okay, I'll carry on. Thanks. So yes, you can see here the different ways of tackling this in terms of improving confidence, but also another way is improving awareness and knowledge. So that might be in general group discussions, might be lectures, workshops, how to recognise unprofessional behaviours, how to informally address them in the moment, how to be a good ally, for example. And this can be a quick way to address unprofessional behaviours, but it's often insufficient on its own, as many of these activities are. You need often a coordinated or brought together bundle or strand of activities, but it can also be a foundation for further content and intervention. So just going to give you a couple of long-term interventions that do have evidence of effectiveness. This one is the CREW from the Veterans Healthcare Association in the USA. CREW stands for Civility, Respect and Engagement in the Workforce. And the emphasis here is on structured cultural change. So it goes across a number of areas, but also on responsiveness. So what they do is conduct a survey, perhaps to understand how and why unprofessional behaviours are taking place. They might ring-fence dedicated time for improving civility, and then depending on the survey findings, implement a range of quite flexible strategies. So it's quite flexible and adaptable to the findings of survey and what's going on in a particular organisation. Others are what are called professional accountability programs. So examples here are Vanderbilt and Ethos, both also originating in the US. And Ethos has been implemented in Australia by Joanna Westbrook, and I'm going to come on to that in a minute as a case study example. So this draws on what's called an escalating professional accountability pyramid, really starting with the idea that most professionals, most people at work are not going to get complaints or are not going to be unprofessional in the workplace, and then it escalates up a pyramid in this way. So if a single incident, you might have informal conversations where data reveals patterns. You might have a non-punitive awareness intervention, and then where patterns persist, and particularly with maybe some individuals or some groups, action plans might develop. And finally, if that all fails, then we get to disciplinary processes, but only then. So the Ethos intervention, just giving you a little case study here. This is the work undertaken by Joanna and colleagues, and their publication is at the bottom here, again with a QR code, which should take you to that. So since 2017, they've implemented it in 8 hospitals in Australia. And the aim is to foster positive culture change, reduce unprofessional behaviours, and improve speaking up. So drawing on reporting systems, where both positive and negative behaviours are reported, often through and then delivered through peer messengers. They have an Ethos accountability programme and training. So it's a whole suite of strategies as part of this intervention. It's aimed at both clinical and non-clinical staff. And as I've said, Joanna Westbrook, who was part of our study team, led an evaluation over 5 years, and that's just started reporting results. So I have some results to show you. So before and after the Ethos study intervention, you can see on the bar charts there, before Ethos, only 6.4% of staff were never experiencing incivility in the last 12 months. That increased to 11.8 after Ethos. So the number of people never experiencing incivility went up. And yet staff reporting behaviours weekly to multiple times daily Pre-ethos, it was 41%, and after was 35%. So a statistically significant drop there. And staff also noted that their experiences of an additional 5 extreme behaviours, so physical assault and demands for sexual favours, also significantly declined. So it's worth having a look at that work. Quite a large study and quite a lot of work to get this implemented in 8 different organisations. But yeah, it looks like it's been worth it. So I'm now just going to share 7 key principles that we identified to enhance intervention design. There were patterns across multiple interventions that we felt it could impact success, and we called these key principles. There's 12 in our report and 7 in our guide. Our report should be coming out soon, our big report. And we also in our guide present suggestions. Our guide, we want it to be quite accessible, user-friendly, being able to be used by managers, but also HR departments, organisational development departments, whole organisations, for how to address challenges in these key principles. And we've arranged in terms of quick wins. So if you haven't got much resource or time, so maybe if you're a ward manager, what could you quickly do and what could make a difference? And then longer term solutions. So if you've got more resource and it's a more of an organisation-wide approach, then you could do these other things. So they're all in the guide. But in terms of the 7 key principles, number 1, and this was very notable in the literature, and it's actually very notable in the staff wellbeing literature, actually. It's the same issue, that it's often blamed on individuals and bad apples. The idea that you've got bad people, you hear this a lot in the press, and we see it also in staff wellbeing. So staff are often blamed for their own poor health or poor psychological ill health and told to be more resilient. It's all your fault. And it's a bit the same in unprofessional behaviours. So it's this idea of identifying bad apples versus looking at an organisation-wide approach where you might focus on enhancing psychological safety and find an environment where it's safe to speak up. So rather than focusing on bad apples, you want systemic organisational approaches to tackle this problem. That's not to say there aren't ever bad apples, but focusing on bad apples actually takes your attention away from the more structural issues that need to be tackled. So encouraging bystanders to intervene definitely helps drive culture change, but it's not without its difficulties, and it might cause moral injury or distress to the person intervening. So it definitely sends the message that unprofessional behaviours are not tolerated, but it might put staff at risk of reprisal or moral injury if they're involved. But on the other hand, not encouraging staff to intervene can imply that managers or others are not serious about addressing unprofessional behaviours. So we sort of see these 2 sides of a coin in these principles. So that's why we've got the versus, it's this or this. And so these tensions we noticed in the literature. Number 3, we noticed very much that authenticity helps build trust in managers and leaders. So if an intervention is perceived as authentic, so when managers and management seem committed to addressing unprofessional behaviours, staff are more likely to give interventions a chance. But on the other hand, if it's perceived as inauthentic, and by that we mean that there are lots of interventions going on, but yet in your day-to-day experience, you're still seeing managers and others tolerating and exhibiting unprofessional behaviours, there's inauthenticity. Or if the intervention appears like a tick box exercise, or managers don't engage, then staff are also unlikely to engage. It's not seen as authentic. And building on that, or related to that, it's crucial to address the behaviours of senior staff. So if managers don't hold themselves accountable too, staff are unlikely to engage or unlikely to need to see that their behaviour needs to change. And if an intervention includes or targets managers, it can be seen as more fair and authentic. Interventions need to be inclusive and fair. So some groups are disadvantaged and require specific help. And it was very notable in the literature how little there was on specific minoritised groups. There was very little targeted specifically or focused specifically on the needs of Black minority ethnic staff, also on disabled staff or trans and other gender issues. And equity, interventions should also include all groups to be seen as fair and equal. We found that if if there were interventions, but they focused on a specific group, it could be excluding, but also unfairly targeted at others. So it needs to be quite carefully handled. And whilst a flexible intervention, such as the crew intervention that I talked about, that could be very adaptive and could be adapting to the needs of organisation, can be quite successful, it can be very hard to evaluate because there's so many different bits and it varies. It's very difficult to see any consistency or understand which parts are actually having the effect. But keeping the intervention context fixed can enhance the ability to evaluate what works. And generally, we found very little evaluation, quite poor before and after evaluation, and particularly in the UK. There are very few interventions to address unprofessional behaviours in the UK that have been successfully evaluated. So we're a little bit behind the curve, I would say, in the UK on tackling this. And interventions to reduce unprofessional behaviours can also enhance speaking up, staff wellbeing and patient safety. So if you're enabling speaking up with online systems, they can enable people to speak up safely and perhaps enable people to engage with those, but it's often not in the moment. So you don't always prevent harm to the patient. Maybe it's difficult to speak up in the moment, like in this illustration here, when perhaps someone's, taking the wrong kidney out or whatever. If it's not safe to speak up then and you report it later, it's not necessarily going to enhance patient safety. But if staff feel able to challenge an error in the moment, this is more likely to be able to prevent patient harm. So in terms of intervention success, we've got a number of messages here from the literature and from our work. So clear messaging important, in assessing organisational culture, using multiple interventions and strategies. One is unlikely to make a difference. Make sure that intervention is just and not overly punitive. Maximise the visibility of actions. Do quite a lot of comms work, show what's going on and that it's actually visible to everyone. Encouraging allyship. Identify and nurture leaders who can tackle unprofessional behaviours, understand about them, and want to make a difference here. Harness existing organisational processes. So in terms of meetings or peer review processes, harness those to introduce issues around unprofessional behaviours. And importantly, involve staff in co-creating interventions. Staff often know what's going on and what's needed, and they're very rarely invited to be partners or help think about what intervention could make a difference in our organisation or in our team. And appointing dedicated staff was found to result in quite a lot more success, where you've got someone leading it and championing such work. So areas to focus on in future interventions. So asking, how is this supposed to work? Draw on behavioural science techniques. That we saw very little of this in the literature. Why are these strategies going to lead to the desired outcomes? What are the assumptions about how this will work? And that was a lot of what we were unpacking in our realist review. What were the designers of this intervention aiming for it to do? And can we unpack that and see, did it make that difference? And what other contextual factors might impact success? And when developing and implementing interventions, evaluate them and provide learning so that others can benefit. As I've said, there are currently no interventions reported or evaluated in the UK literature. And we did notice, as I've said, this undue burden on women, ethnic minority and disabled staff, with also other particular groups like new staff, shift workers and agency workers also affected. And this impact should be definitely acknowledged, and perhaps interventions designed specifically to address this, with the caveats I've said that actually sometimes including everyone can be the best approach. So where can you get the guide? There's much more information about our study. There's a longer webinar on our website, and the guide is there. Before you get the guide, we just ask you 3 short questions about who you are, where you are in the country, and if you would be willing to give us your email address. You don't have to give us your email address. That's because as academics, we're asked to measure our impact of our work. So it'd be really helpful to know who's using our guide, who's downloaded it, and can you tell us what you think of it, and has it been useful? So you will get the guide. It's just those 3 questions, if you don't mind. So finding out more, I'll make sure you get these slides via colleagues. So we've got various papers here that we've published, and our final NIHR report is to be published very soon. So that was all I wanted to say for today. I hope that's been interesting, and very happy to take your questions. I'm going to stop sharing now. Thanks.
Thank you, Jill. Wow. Lot to think about there. Before we go to the questions on things, Joy, is there any particular, since you're one of the stakeholders, is there any particular question you want to ask now, or maybe a bit later, before I go to the Christiana?
I'm happy to go a little bit later. I found it a fascinating process to be involved in, and I'll just echo what Jill said about how some of the research, especially in relation to Black and minoritised ethnic groups and other minority groups, how that doesn't quite come through yet in terms of what to do in particular about those groups of people. But yeah, there's loads in the chat, actually. I've just been reading the chat, Jill. You've stimulated a lot of conversation and debate already. So perhaps we should look at the chat.
Okay, Christiana, do you want to pull a couple of questions out? And I've got one for Jill myself, but let's have a couple of questions from the chat, please.
Absolutely. We have just a query here. Are there any interventions on working with leaders who become defensive as a default position when poor behaviours are highlighted?
Thank you. I think there was definitely some issues around that in the literature, and so leaders need both encouraging and supporting. It's not an easy thing to do, but I think I'll ask Justin to come in a moment because he's read the literature much better than me. But where there were more systematic approaches like Ethos and Vanderbilt, where there were a number of ways, I think leaders felt that there was a system that supported them to respond and engage, and that was potentially more helpful. Justin, I don't know if you've got anything to add.
Justin, if you want to chip in, please do. You're on mute. You're on mute, Justin.
We can't hear you, Justin. You're not on mute, but we can't hear you for some reason.
Oh.
Maybe your microphone is disabled in some way.
So maybe while Justin is sorting out his microphone, there was a comment in the chat about the just culture that the NHS is trying to implement, and comparing that potentially to Crewe, suggesting that whilst Crewe may have been successful, people are struggling to implement the just culture. Can you comment on that, Jill?
Yeah, I totally, I mean, I have lots of sympathy. I understand it's really difficult. So in terms of a just culture, it is a non-punitive, supportive learning culture. And psychological safety is very much part of that. So if you're enabled to speak up and share, and it's non-punitive, I think we have a lot of defensiveness in the NHS, and we have a lot of reputational management by trusts. In my career, I'm not sure it was ever thus. I think there was a lot hidden and a lot swept under the carpet when I was a younger nurse. But I feel like since the reorganization of trusts and the competition, there seems to be a huge amount of reputational management. And I know others have written about this much more than me. And it seems like once the lawyers get involved, it becomes really, really difficult and issues get shut down. I read a really interesting paper yesterday I'll try and find it and put a link in the chat, from a colleague who was in the Navy in BMJ Leader, who talked about how a just culture in learning from a near miss of an accident between 2 fighter pilots was very much very different to his experiences. He's retrained as a doctor in the NHS, and how he was encouraged to, and he noticed in a just culture that there was a lot of focus on anonymity as a way of managing that in the NHS. And he didn't say this, but I would say that that is because it's not safe. It's still not safe to speak. And even when trying to establish a just culture, he kind of understood why they were trying to approach it through anonymity in that way, so that people weren't blamed. But he was saying, in his experience of this mistake he made, what was really important was that he owned it, he identified it, but he was supported and nobody was pointing a finger. It was all about learning and sharing the learning. And he was encouraged to write it up and share with other colleagues so that everyone could learn from it. And we're so far from that at the moment in the NHS that a just culture is a great ambition, and it'd be fabulous to see, but I'm not sure how we're going to get there with the current systems that we have and the current punitive approaches to staff. Reading that paper, it did make me helpful. Sorry, reading that paper, it did make me wonder if one of the differences he was talking about was just his experience was with colleagues. He nearly killed two colleagues, two jets nearly crashed into each other, but there was not patients and the public involved. And it did make me think how performative organizations have to be to manage patients, public, politicians, and often patients and the public can be very punitive in trying to find out not what went wrong, but blame someone, and that can be very, very detrimental. Just my reflections from yesterday's reading, but I hope that's helpful. I'm not quite sure I've answered the question though.
Justin, do you want
I
to...
think you probably have, and there's lots of comments in the chat resonating with what you say. Roger, you were going to bring Justin in. Thank you, Jill.
If your voice is now hearable, if that's the word, do you want to chip in, Justin? You're still silent. Sorry. I will come back to you, I promise. Okay, let's Christiana, do you want to read out another?
I think we can hear you, Justin.
Okay. Hello, everyone. I was a research fellow on this project, as Jill mentioned previously. I'm afraid at this point, I've essentially forgotten the question, but I think it was about leadership. Is that right? And
leaders being defensive, it was, Justin. And I suggested that maybe with situations like crew or ethos, where there's a range of supportive interventions or something happening, it may enable people to be less defensive, but I don't know if that's entirely true.
I mean, there wasn't too much in the literature about leaders being defensive specifically, but of course there's a lot about this notion of authentic leadership, leaders being open and receptive to messages. And I think this also ties in with the notion, of course, of organizational deafness as well, that when these concerns are raised, that managers and leaders need to not only hear them, but also act upon them. And that's obviously a big issue in the NHS at the moment. And connected to that was the notion of authenticity that Jill talked about, in that if these interventions or programs that are rolled out do not include some form of accountability for managers or leaders within that, then it is also less likely to be engaged with by staff who are not in those leadership roles, because they will not see it as something that's likely to be effective. And unfortunately, we see in the NHS staff survey that a significant portion of colleagues say that they experience unprofessional behaviors from their managers. So it's a reality and not just a theoretical thing.
Christiana, you got another question?
Absolutely. I'm going to go from the Q&A. So yeah, just another encouragement. Please use the Q&A because we just don't want to lose your messages in the chat. Thank you so much, Catherine. Why does the staff survey not address this better? This would be a good opportunity to see patterns reported within teams without individuals needing to take responsibility of reporting.
Great question. I've done some work with Jeremy Dawson, who is very does a lot of designing of the staff survey and developed the original staff survey with Michael West. I think they are looking at some of these issues and definitely looking at trying to measure better staff wellbeing, including burnout. But in terms of unprofessional behaviours, I think it's quite difficult to get robust measures in the NHS staff survey, and it's quite a long lead in. That's not an excuse, it just is a fact. So I do think that this is a moving feast and it will change, but we just haven't got it yet. And the other reason not to change questions too often is, of course, you want to be looked back and have some longitudinal data with which to compare. So if you keep changing, I'm not suggesting you're saying we keep changing it, but if the questions keep changing or are different, I mean, adding questions is a bit better, but then you've got to think about, will staff complete it if it gets longer and longer? So there are challenges, but I hear you, and I think we could do with some better data. Thank you.
Christiana?
Justin is
Justin,
going
do you want
come
to
in?
come in? Yeah.
Yeah, I just wanted
Justin,
to add something quickly in that Joanna Westbrook, who Jill also mentioned earlier, she did a big survey as part of this ethos evaluation and actually found that a lot of the staff in Australia across those 8 hospitals, they report that actually general rudeness and more mild forms of unprofessional behavior, they feel have a larger impact on patient safety than the more extreme types of unprofessional behavior. And perhaps that's due to their pervasiveness. But of course, on the NHS staff survey, we don't currently have questions about these more mild forms of unprofessional behavior, like rudeness and incivility. It asks about bullying and harassment and discrimination, but these are quite high bars. And so actually a lot of the milder and more widespread, but still insidious behaviors are not captured. And maybe it's possible to add a question about that while still capturing the same information as before to perhaps help solve some of these problems.
Christiana, another question?
Absolutely. Thank you to Joanna. I'm curious about finding that reporting incidents can lead to moral injury for some. I wonder if there were any findings to suggest that not reporting incidents can also cause moral injury for others. I would guess that both could be problematic for different people. Really interesting and important work. Thanks, Jill.
Thank you, Joanna. And yes, I'm not sure we found much in the literature about the non-reporting, but I can absolutely imagine that if you saw unprofessional behaviour and you didn't feel it was safe to be an ally and stand up in the moment or report that actually that would eat away at you and trouble your conscience somewhat. So I can imagine there could be. I think you're right in supposing that. Justin, did you find anything specific about the of not being an ally?
So I think that is, yeah, one of our findings really is that the people who are encouraged to chip in and defend someone else, but then don't feel able to because of the culture, they are the ones that will then suffer moral injury. But I think, like the commenter here is saying, obviously, if you are a victim of unprofessional behaviors or a recipient of them, and someone doesn't step in for you, that is also chips away at the, one of the drivers we had of these unprofessional behaviors, which was the social cohesion in the first place of the workplace. So you kind of see these vicious cycles happening where people don't step in for you. You then feel more alienated and ostracized within your workplace, and it just gets worse. So there's a careful balance to be struck there. And the only real solution to that problem is creating an environment in which there is a lower risk of reprisal for the people who step in to defend people who experience unprofessional behaviors.
Christiana, then I'm going to ask Joy or Mary if they want to ask a question as well. But Christiana, do you want to take another question from the chat, please?
From Nicola, when interventions are implemented, do numbers of instances go up due to staff feeling empowered to report bad behaviour? If this is true, how can interventions to address and improve bad behaviour be measured as successful? Really
great question. And I think there was something in that when certainly from speaking about the other project, the Freedom to Speak Up Guardians evaluation, I think that's a real challenge. So does more reporting mean that the culture is getting better? Is it a good sign that actually people are now encouraged to go to and got somewhere to go? Or does it mean that there's a viper's nest of unprofessional behaviours in that organisation that is just being shown? And I think the numbers game is really tricky. In the ethos programme, Justin, did I presume that did happen, that there was more reporting?
I'm not actually sure because I've only seen the figures from 5 years afterwards. I think if you actually measure it over time, you would expect there to be an initial increase and then a sort of gradual fall off in the reporting of unprofessional behaviors. And interestingly, this commenter has thought about it well, because we did find, I think there were 4 interventions that reported themselves as unsuccessful because their number of reports increased. But actually, you could say that's a success of promoting speaking up, which is one of obviously the things you might want to do. And so that also connects to this sort of lack of behavioral science and lack of thinking through outcomes that we found in the interventions that were reported in the literature, in that they didn't really understand that, improving speaking up will lead to an increase in reports, but then obviously that might lead to so-called more unprofessional behaviors being reported. But another way of going around that might be to measure the harm caused by unprofessional behaviors and see if staff report that going down, or if they report less impacts on patient safety or care quality. Those are a bit further down the sort of causal chain, but things like staff well-being are quite connected to unprofessional behaviors. Or if you can ask questions about staff well-being impacted directly by unprofessional behaviors, that might actually be a better indicator.
Joy or Mary, do you want to ask a question before we go back to Christiana?
I just had a really quick question, Jill or Justin, actually. One of the things that I found really interesting about this work is the idea of realistic review and methodology. And one of the things that I noticed with the NHS is it does a toolkit, and that toolkit goes all the way around the place. It doesn't really work. So, I mean, is there a message about the use of realistic methodology? Because it seemed to me that was a real plus in terms of this in this work. How is it going to work? Why does it work, and for whom it works? Which I think is the granularity, I think, that we need to get to.
Thank you, Joy. Yes, I'm a big convert to realist methods. I think it does enable you to get underneath the does it work, and who does it work for, who's most perhaps at risk. Certainly, agency staff and newly qualified staff may be more at risk. So you understand the who better. But also, I think it gives, and I noticed something in the chat saying, this is a very complex issue and it's very nuanced. And I think it is, and it's not a one size fits all. And I think that's what realist methods gives you. But from our point of view, it enabled us to see these, what we called tensions or dynamics in the literature, those principles we presented as, it might mean this or it might mean that. It's not black and white. And it's actually some of the principles we've come up with is a way of trying to share some of that complexity, but also, the big message really is do something. It's not okay to just not be doing anything. And the fact that there is no comprehensive program that can be adapted in the UK that has been evaluated. That's not to say there aren't things going on in the ground. We've got the civility toolkit, we've got all sorts of things, but without the evidence, I would say that an academic, we can't really know how it's working, and is it effective, and is it worth putting money into, and what are the unintended consequences, and where might it work better, and for who, and do different staff need different things, different groups of staff need different things. So you're absolutely right. Realist methods allows you to get underneath some of the taken for granted assumptions. And for that reason, I think it's incredibly valuable.
Thank you. Mary, do you have a question before I go back to Christiana?
Yes, just very quickly. I mean, you've highlighted one of the problems being organisational defensiveness and the go-to sort of reputational management approach. Are there any interventions, or what do we know, kind of opens that up? Have you come across any interventions that have tackled those areas specifically that have proved to be successful?
I mean, interventions, I guess there's some programs that are trying to promote excellence. And it's a tricky one, isn't it? Because if you get excellent, then you've got your reputation is secured. And in places like the US, where patients, have got a lot of choice, and something like the magnet work, which is about creating excellence, but it's a magnet. The idea of magnet is it makes it a good place to work. So it's about good teamwork, civility, but also encouraging people to have job satisfaction. Then the magnet is that it encourages people to stay, but it also attracts patients. That's the idea of the magnet. But I guess, yes, I don't think we found anything that was really going to address reputational issues in that way. It's fair to say. I think it's really challenging, and I think organisations struggle because they're also blamed by, it's very difficult in this system we have for. It's a brave organisation that takes a different path. But I suppose I would recommend the work of Amy Edmondson to people talking about psychological safety. So if anyone hasn't read her book, she's got a new book out about teamwork, which is brilliant. But she's also written a lot about organisational psychological safety and gives examples from outside of healthcare where CEOs and others want to learn. They want to hear the mistakes. They want to know what's going wrong. If they don't know them, that's what's going to keep them awake at night. So the idea that you want to know a mistake or someone is berating someone else and improve culture, that is so important for the bottom line for a business. So it makes business sense to do it, which is why organizations outside health might take this approach.
Thank you.
Thank you. I do wonder how ready we are for this, radical systemic change within our NHS. Thank you.
Christiana?
I'm going to read the next two.
5 more minutes, so probably 1 or 2 more questions.
I'm going to read the next 2 questions. One's about sustainability and one's about impact. So from Jacqueline and Ellen, how can you guarantee that this template, if and when it is adopted by organisations' leaders, is or will ensure sustainability and progressiveness for the organisations to move the dial and really tackle the root cause of the unprofessional behaviour going forward? And the question about impact, how do we impact these behaviours earlier on with consideration of the NHS complexity, especially around sociology of the professions and our independent learning in silo as professions rather than learning as an MDT workforce from the start? It feels like a lot of the contributory factors are bred in from the start of people's professional careers from students onwards.
Wow. Okay, there are a lot.
Sorry.
I'm not sure I captured all of that, but I can say
impact and sustainability.
Impact and sustainability. Thank you. Yes. I mean, in any intervention implementation, sustainability is huge. And we know there's turnover of staff, there's less resources. I don't think we can say categorically that our suggestions are going to move the dial. We'd love that they did, but I guess they are a call to arms really more than anything. I wouldn't call it a template. I would call it principles to help people think through what's important to them, how to role model. I'm seeing quite a lot in the chat around walkarounds and how important it is to be visible. That's also, Amy Edmondson talks about that in her work, and how the visibility and role modeling good behaviours can be so influential and important, and what's tolerated and living values. So I don't think we're saying here's a template, we're just saying here's a guide, here's some principles, this is what we found from this big review of the literature, sort of synthesizing it all for everyone. We don't have immediate solutions. There is not an off-the-shelf thing, but neither should there be. And in terms of impact, my plea, I guess, is to get some before and after data and do some evaluation and use some theory to evaluate before you do anything, so that we really know whether it's working. Otherwise, we're not really going to know the impact of any work. And that's one of the challenges we have in the UK, that there are some practice-based solutions going on, but we don't know how effective they are.
Justin, is there anything you'd like to quickly say before I sort of close the session?
Not too much other than to say thank you. There's been a lot of engagement, so many questions and things in the chat that I'm struggling to keep up. But we really appreciate the engagement, and we're glad that everyone finds it to be important research. And we're looking on continuing this research in some strand or another, including someone just mentioned, investigating, the link between staff experience and patient experience. So we're actually looking into doing some research around that as well, because these are indeed important questions and concepts that underline the whole reasons for this work.
Okay, I'm going to start to close it. So first of all, you used the phrase "a call to arms," Jill. I thought that was quite a nice way of summarizing. This is kind of throwing a big pebble in the pond, which I hope people will read, and organisations will think about what has some reasonable likelihood of working before they jump into doing things and then find out a year later that it didn't work and probably was never going to. So thank you both very much for joining. Thank you, Christiana, for kind of being the glue that holds all this together. Thank you, Joy, for questions and joining. And thank you, Mary. I think I'm right in saying that the recording will be available. We'll send that to everybody who has joined it. There was a question about the slides separately, but my guess is if they're part of the, maybe if it's possible, Jill, could we send out the slides separately as well?
Sure. Yeah, I can send them to Christiana.
Right. Okay. So we've had a really good attendance today. Thank you very much. Really good discussion. Thank you, Mary, for kind of enabling it all to happen. And it's 1 minute past 1. I'm going to close it and thank everybody for joining us, and thank you for everybody who asked questions or answered questions.
Thank you. Bye-bye.
Thank you,
Thanks,
Roger.
everyone.
Our next
Mary.
session is on
sorry.
Thursday, March the 14th, when we'll have Professor Graham Martin, who's the director of the THIS Institute. And the link for that event is now live on Eventbrite. So please go to and sign up. We look forward to seeing you on the 14th of March at 12 o'clock. Thank you again, Jill, Justin, Roger, Joy, and Christiana.
And thank you, Mary, because I completely forgot to do it. So thank you. And Joy will be chairing that one. So that's great.
Lovely. Thank you.
Thank you.